Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System, broadcasting live with you from the Dulce Simons Family Studio. I'm joined, of course, in the studio by Doc Hawk. We're also joined by Patrick Mahomes, well, his bobblehead, and a Chiefs Cup, demonstrating once again that when Big Red takes it home, we're right there with him.
That's right.
It's the best. We're with him, win or lose, but
yes,
it's more fun when we win.
It's much more fun.
We're also joined by Phil Griffin, KDHE Director of the Bureau of Disease and Prevention, who's going to talk with us about how a vaccine would roll out across the state of Kansas once approved by the FDA. Now, this is becoming more of a reality. Pfizer announced, I believe yesterday or late last night, that they hope to file information with the FDA for an early use authorization. I think I read it was going to be in mid-November. So that's a big step forward, if indeed that holds out to be true, with their vaccine. We'll have to talk about what the implications are for that and what it could mean for vaccine development here for COVID in our area. But first, Doc Hawk, how are the numbers?
Numbers are quite a bit better today than they have been.
I like that.
We were concerned they were going in the wrong direction.
Going in the wrong direction.
And continue. Well, we thought they were going to continue. So far, it's good. And again, I think we are going to see just these vacillations week to week, few days to few days. So today we have 27 active patients in-house, 11 in the ICU, still 7 on the ventilator. So a high proportion of our ICU people are on the ventilator still about 30 in that recovery period. And then Hayes has 16 total patients, 15 of which are active infection, and 1 is in that recovery phase too. So their numbers are decreasing as well, which is a good thing. Yeah,
but we're all still busy. You were reflecting a moment ago on the look at Kansas City and our rolling 7-day average.
Yeah, based on kansascity.com, back on September 13, about 5 weeks ago, we had 262 new cases per day. Again, the rolling 7-day average. Today we're up in the 420s. For new cases per day on that 7-day average. So overall, the rolling 7-day average is definitely going in the wrong direction and has been now for the last 4 to 5 weeks.
And we know that the rolling 14-day average is reported, I think, in the New York Times, is still up 35%. Yeah. And so overall, that yet another example of how COVID continues to increase in its intensity out in the public. Well, Jill, let's see if there are questions first from media, and then I want to interview Phil Griffin here in just a moment. So let's start with the media, though. Okay.
I don't have any texted to me today, so let's go ahead and dive in.
All right. So, Phil, lots of stuff going on about the vaccine. When do you think a vaccine is going to get approved? What's your information telling you?
We pretty much get a lot of what everyone else is hearing right now. We do know that yesterday Pfizer announced that they were not going to put their information forward for FDA EUA approval until mid-November. There had been speculations they were trying to get that done this week or early next week.
Yeah, I remember that. They also, at one point, they pushed it off to the end of November because the cycle went, I think, end of October, end of November, now middle of November, which I'm going to say is probably a positive sign for when they think they're going to be ready. I doubt Pfizer is going to really care too much about the election. I think they just want to get the vaccine out so they could start getting people going on that. So what do you think about that? Is that going to be too early, and are you comfortable with that, or will we get a vaccine started even if there's only one? Because there was that whole warp speed thing where supposedly you had to have at least 2 different vaccines, but Pfizer's isn't in warp speed. So how is that going to play out?
That's the million-dollar question. I think if anybody could answer it right now, we would all be much better off. But certainly what we know is there are several in development right now, a couple that are looking pretty promising to be moving toward the EUA approval mid to late November. What's important to understand, too, though, is it's going to be a very limited amount of vaccine that does become available immediately when that EUA does come into play. And then it will be what every indication is that we're getting from CDC and other federal partners is that will then ramp up at a fairly significant pace. But initially, that will strictly be a very limited amount that will be focused at those that are at greatest risk of being in contact, healthcare workers. And in this definition of healthcare workers, it's all those that would be working in a healthcare setting in hospitals that whether volunteer or paid positions, medical and non-medical, that are actually in contact. So we'd be looking at housekeeping, anybody who is unable to work from home, essentially in a hospital setting that is going to be in contact with potential COVID positive patients.
And then will that go into with first responders as well, police, firemen, et cetera?
We are working at a 3-phase process is the way CDC has laid it out for us right now. So phase 1 is actually a phase 1A and a phase 1B.
Okay.
Phase 1A will be focused strictly at those immediate hospital type of contacts, and then phase 1B will also include those additional first responders and begin to move into high-risk populations, particularly nursing homes and long-term care facility staff and residents. And we don't expect a great deal of distance between phase 1A and phase 1B. The big question will be how much vaccine will we actually get in Kansas or in Missouri in those early phases, because it'll all be done through an allocation process nationwide based on the availability of vaccine.
You bet. So let's go ahead and talk then. What if with those phase 1A and phase 1B, the sickest of the sick, the most vulnerable, then who's in phase 2 and who's in phase 3?
Phase 2 begins to open up with a first priority to all those essential workers. And all of these priorities are certainly, the important thing to know too is that everything is changing constantly. So what we anticipate right now is it'll initially roll out, but phase 2 it'll be more widely available and pretty much open to all those essential workers and the rest of those that are at greater risk, and then moving right on from that very quickly into general population. And that they're telling us should happen middle of next year, spring to middle of next year. And then beyond that, go into phase 3, which will be full market availability.
Okay. And how is it going to be given? Who's going to be giving the vaccine? Where will it be shipped to? Will it come to healthcare providers, hospitals, CVS? Where will it go?
Yes, to all of those. It's going to be, we're working right now on beginning to enroll providers. We expect to open the enrollment portal next week, and that will be targeted first at hospitals that are caring for COVID patients and also the health departments. And then we will immediately, as we get those all enrolled, working with our partners, we will then move on to enrolling all types of providers. On Friday, there was an announcement from HHS that they have secured agreements with Walgreens and CVS to be a national provider to long-term care facilities. And actually enrollment in that process started yesterday with long-term care facilities that go through a REDCap portal with HHS and begin to go ahead and enroll and indicate their intention of using one of those two to come in and vaccinate their populations and their staff. And they'll be scheduling then with Walgreens and CVS to do 2 different times if it's a 2-dose vaccination or a 2-dose vaccine that they're using. And then beyond that, if there are relationships and already set up with other pharmacies or with hospitals that normally provide vaccinations to those long-term care facilities, or if it's a long-term care facility within a hospital, there will be mechanisms for them also to be able to get that through the state allocations that will be coming. So we'll also be enrolling people to do that as well. So we will be using as wide a range of vaccinators as possible. Eventually, by the time we get to phase 3, we'll be using a lot of private and local independent primary care physicians and things of that nature. So any place that we can find a means to get vaccine out, we will be working to get that out.
How do we convince people that because we've been working on this program every day, Hawk, how do we convince people that it's safe, Phil?
I think the most important thing, and it seems cliche these days, but it's really to follow the science. I personally will pay a lot of attention to what the Advisory Committee for Immunization Practices, the ACIP, to what they say. They will be reviewing everything as FDA approves it. They have committed to an emergency meeting. Usually that group only meets once a quarter. They have been meeting monthly in preparation for this, and they will, within ACIP, there are work groups, and those work groups are really delving deep into the science and looking at all the studies. I have previously served on one of those work groups and know the depth of which they look at every single study. So not just looking at a meta-analysis, but looking deeply into each and every study and having good, solid debate. So I'll be real interested to see and hear what those experts are saying. And that's a group of people, physicians, different types of providers, epidemiologists, that are working across the gamut. So there's a lot of perspective being put into that. So I think what they have to say, certainly what FDA approves or does not approve, and then just looking at, there will be ongoing information immediately as well, too. As soon as the vaccine hits the market, there's post-market monitoring that goes on. We'll be looking at everything that's going into any kind of injury or concerns that are being expressed through bears and things of that nature.
So what do you think if they have Pfizer? Moderna's not ready yet, but the Pfizer data looks pretty good. I mean, they've said they wanted two, but I'm got a feeling that if one looks good, they're going to get started. What do you think?
Yeah, I think certainly as soon as something's available, there's going to be a start.
Yeah, there's too much pressure.
The challenge is going to be that whatever vaccine you get on a first dose, if it is a 2-dose, you'll need to get the exact same vaccine for the second dose. So part of the challenge with a single provider is obviously the breadth of being able to get it out to the full market as quickly as possible.
Yeah, it'll be interesting to see how this plays out. Because I have a feeling there's going to be a lot of vaccines available all at once, or at least over a very short period of time they'll start rolling in. And then it's going to be, well, which one do you get? And that I think that's going to be the confusing part. What do you think? How are you guys going to look at that? And how will we design trying to get that out to everybody?
That's certainly going to be a challenge. And one of the things that's required is everybody will get a card that with your first dose, and that will tell you when you should come back for your second dose, and and which vaccine you're supposed to have, and those types of things. Of course, we all know what vaccination immunization cards happen. You lose them about the time you walk out to the parking lot. But the real advantage I would say we have in Kansas and throughout the entire COVID vaccine rollout too, is that everyone is required to report all their doses to the IIS, the Immunization Information System. Each state has one. Missouri and Kansas actually both use the same. Missouri has just moved into a WebIZ product. So both of us use the same platform, and those doses are all required. One of the agreements that all vaccinator organizations will sign states that they will submit that administration of a vaccine within 24 hours. So all of that will go into an electronic system that is also available then to vaccinators to be able to look in and see exactly what your history is, what your vaccine was that you received previously, and so to be able to match that up the second time around.
Yeah, this sounds like it. You all have put a lot of thought in this. How do you feel about the distribution system? Do you feel like we're ready? I mean, because it feels a lot like some of the thinking that had to go into remdesivir when there were only limited doses, and how we're going to distribute that.
There is a continuing on, and it is going to be a big lift. There's no hesitation in saying that. I do think that we have a lot of experience with the Vaccine for Children program on doing vaccination distribution through centralized systems. And so the same similar situation will be used. CDC will use McKesson as their vaccine distributor through the McKesson warehouses, and they are standing up additional warehouses across the nation to handle the larger volume. We already work with them, again, through the VFC program in doing multiple vaccine distributions through that program, as well as some other CDC programs, 317 and others that also provide vaccine for adults. Our flu vaccine comes through this process. So a lot of the providers that will be enrolling will already have that experience in using that process with us. So I think that will be an advantage. Now, the one caveat to this is that at least the Pfizer vaccine, it looks like it's going to be a super cold vaccine. which will be shipped directly to providers through the allocation process. So instead of going through McKesson, it'll go directly out to the vaccination sites. One of the challenges that is going to hold is the fact that it is a super cold, meaning that it's about 70 degrees below zero, the storage,
Oh my goodness,
and not
yeah.
everyone has capability. So there is a special shipping box that is being developed for that will hold the vaccine for about 10 days, is what we're being told right now. Be able to open that twice a day to pull vaccine out. It will come in large quantities, and which will cause a challenge there too, and then we have to look at exactly where we can put those and be able to vaccinate the right numbers to not waste vaccine in a short period of time. It's projected right now that it should be vaccine that once reconstituted can be stored at refrigerated level for 5 days.
Wow. So here's the burning question then. Once that shipping container is done, can I get one to be an ice chest? Because that will revolutionize my camping experience.
Well, and I tell you the most interesting thing about it is they call it a pizza box.
Okay, well, maybe that won't work quite as well, but I can maybe I have
No beers in there.
I guess so. And finally, Phil, are you going to get a shot?
I will. And like I said, I will personally base a lot of my decisions and experience on what ACIP states.
Well, that makes sense. Yeah.
And as soon as they say it's good, I'll be there to do it.
Hawkeye, what are your thoughts about this whole thing? We've been talking a lot with Phil. You spent a lot of time studying on this, infectious disease doctor and all that stuff. What are you thinking?
Yeah, absolutely. I mean, I think starting is the distribution and where is it going to be. We know that there are transport issues, temperature issues, but once all that is sorted out, certainly we have a flu influenza vaccination group here and a task force here at the hospital. And just as Phil said, there are already protocols and systems in place. They're going to be tweaked a little bit with the COVID vaccine, but if people can use those base protocols, and that's what we're doing here. And of course, Tim Williamson is leading that effort here, and we are in good, close conjunction with our influenza vaccination team. Once we can do that and get it on site and be able to give it, and then of course I think it is going to be important for ACIP to make their recommendations. You would hope there would be minimum requirements for the efficacy. So really, most of the vaccines should be similar across the board as far as side effects, adverse effects, and then of course efficacy as well.
Yeah, this has been very helpful, Phil. Well, Jill, let's turn to the public and find out if there are questions out there.
Oh, yeah.
There are
got
questions,
lots
you
of
think?
questions.
Oh, there's a shocker.
And they came in so fast that please forgive me if I ask something that you've already answered because I was
Okay.
trying to divide my time.
I'll filter it right out. We're
Yeah,
good,
all
we're
right.
good.
So Isaac wants to know if, what are they going to do in the bi-state area of Kansas City Metro? Will Missouri and Kansas be coordinating? Will
Oh, that's
Mid-America
a
Regional
great
Council be
question.
involved?
How is that going to work out, Phil? I bet you've been involved in that planning about what happens in the metropolitan area about with the adjoining states.
Sure. We work closely with Missouri and will continue to do so. One of the really wonderful pieces is that, as I mentioned earlier, WebIZ is now being used by both sides. And we already have an agreement in place that we can share data between our two systems.
Yeah, tell us what WebIZ is, because I bet most of our listeners won't know.
Yeah. WebIZ is the Immunization Information Management System. So it's an electronic surveillance, it's an electronic registry that is web-based and allows for all vaccines to be followed in there by the patient level. So in Kansas, it's now a requirement as of July 1st of this year that all vaccinations from birth to death are recorded for anybody vaccinated in the state of Kansas. So those are in there, and it's been there for many years with children. It's always been available to adults, and now it's available for everyone.
And so if I'm a Missouri patient, but all my doctors are in Kansas, and I'm a high risk, where will I go to get a vaccine? Can I go to Kansas and get that vaccine?
Absolutely.
Okay.
The whole point here is to get vaccines out. It's not a matter of which side of the line we're on, and we're certainly very aware of that. In Kansas, Missouri, we've always shared the Kansas City state line, and that will always be. We're unique in that way that nobody else in the country really has that exact structure.
Yeah, we're kind of funny around that one. So in this case, it's not a border war; it's border work. I like that.
Absolutely. Absolutely.
All right.
You're
That's
so
my line of the day.
clever.
I'm done. Okay.
Yeah, all
I'm
right.
going home.
Craig has a question that kind of a lot of people are asking too, and it's a discussion around if you can be infected a second time. It's two-parter. Like, can you get it again? And I think we've said yes.
Yes.
Are you as contagious? But the other thing is they want to know how herd immunity and vaccinations work.
Okay, so
together
let's
or
take
apart.
that one on.
Great.
Yeah, herd immunity and vaccinations, how that fits together. We're going to turn to both of you. We'll start with Hawk because we know that you can get reinfected.
Yes, we don't know who can get reinfected or how soon after the infection. Is everybody susceptible to that? We don't know. I think part of it may have to do with your initial symptoms and the immune response and how robust was it. Obviously, we have seen evidence that if you have more severe or critical disease, you tend to have a higher antibody titer. And we use the antibody titer, the neutralizing antibody titer against SARS-CoV-2 as kind of a proxy for the immune response. Now, certainly within that, we know that your antibodies can wane with time, and that differs from person to person as well. But there should be some memory response. So the B cells that make the antibodies, but also the T cells that help to take viral infections out of your body. So all of that comes into play. So yes, you can get reinfected. We have seen more and more reports of that. Some at 142 days, some as soon as 60 days. But we don't know who's going to be susceptible to those reinfections, and we don't know what's going to happen when you get reinfected. Will you create enough virus to be infectious? Possibly. Will you have worse symptoms or no symptoms or better symptoms than before? We've seen the gambit in the published cases. So we are starting to learn that. How will that affect vaccination and herd immunity? So again, traditionally we thought of herd immunity as most of the population that is either vaccinated or had the infection and become immune to it. Traditionally, that's been 85 to 90%. I just saw an article today in JAMA Network, so the Journal of the American Medical Association, that really looked at it using the replication number, so the R naught. How many people does one person infect? And certainly for something that is truly airborne, like measles, we have talked about this, the R naught tends to be 12 to 18, so very high.
Very high. Bad news high.
Since the beginning, really the R naught or the replication number for SARS-CoV-2 or COVID-19 has tended to be in that 2 to 3 range. So based on those models, they are saying herd immunity, can be obtained in that high 50s to 70% range of people who are immune either through vaccination or infection. But we still don't know. And again, the real caveat to all of these is that we know that you can get reinfection. So we don't know how all of this will play out. Those will be questions moving forward that we are trying to answer. How much does natural infection protect you against reinfection and all of the consequences that come with it? And how well does vaccination protect you against reinfection? And for how long? Phil had mentioned durable. How durable? What is the durability? What is the length and the time frame that you do have that immunity?
Phil, thoughts about that as well, about herd immunity and vaccination? I don't think we want everybody to run out and get sick all at once. I saw that the Barrington group kind of said something about that. That seems like an incredibly bad idea to me.
I would absolutely agree. And, the challenge is our goal with vaccinations is 80%. Obviously we'd love to have 100%, but the real goal is realistically is 80%. And again, that's looking at where that herd immunity likely would be, putting a little fudge factor in there. And, but, the challenge right now is people are believing that we could get to herd immunity. Well, right now we're at around 3 to 5% population that's been infected. So that's a long way between 3 to 5% and 70, 80%, even if 50%. And there's a lot, when you look at the numbers and the severe illness, the hospitalizations, the deaths that occur to get to that point, I personally just think it's really pretty absurd to try to send everybody else to get sick to get there.
That's just a terrible idea. In fact, for smart people to come up with that, either I totally am missing the boat, or it's just an impressively terrible idea. And I think it's the latter, because it says, yes, we can do that and keep the economy open, but the downside is A, we have no idea what the risk factor of doing that is. B, we have no idea how much we would overwhelm healthcare resources, because the theory that you can get only those who are healthy sick, and we won't let the 60-year-olds go out, that would include me, by the way, the 60-year-olds go out and get sick. Well, really?
Right.
Does anybody think that that's really possible?
Yeah.
I don't know. I'm a little stunned on that.
We
one.
know, I think it was Denmark that had tried that model, Sweden. But unfortunately, what we fail to see and mention is that their death rates are 5 to 10 times higher than their neighboring countries.
Yeah, they're really bad. They are not doing well. And so, yeah, I think the example of, well, we'll just not pay attention to it probably hasn't worked very well.
Simone wants to know if you get less than 80% vaccination rate, are you considered successful?
You know, I think the answer to this, Phil, is going to be yes. We're still, to Dana's earlier point, if we had 50, 60 or above, it feels like if we're at 70 or 75%, that's still a pretty darn good success.
Yeah, absolutely. You know, we look at annual flu vaccination rates in some populations, that's as low as 40%. And we're certainly this year are really pushing hard on seasonal flu and really want to encourage and take this opportunity to say, please, if you haven't already, please go get your flu vaccine.
Hawk and I did that 2 weeks ago on this program in this studio on a Wednesday. It'll be up 13 days.
We should be protected now.
We're ready. Bring it on.
We want to set those goals high and know that it may not be fully achievable, but if we don't set it there, we're never going to get there.
Yeah, and I think every time we do it, it just takes you one step closer to being safe. And honestly, we can do that one step closer to being back in at Royal Stadium and back at Arrowhead. Because I promise you, we beat the Raiders at Arrowhead if that 75,000 people are going full throttle.
Sydney asks if there are multiple vaccines that end up being available, how will they determine which is given in which areas and which should I go get?
Well, that's a great question. Yeah. It's kind of unanswerable because we haven't seen the data. I think eventually we're going to look at this and we're going to say which one has the best efficacy, which one lasts the longer, and has the fewest side effects. And then once we pull out that information, we'll have a pretty good sense of which one we all want to take, and we'll have to have it be available. So there's 35 or 40 vaccines that are in trials, and 5 of them are in phase 3. And I mean, it's a crazy high number, and all these companies are putting a lot of money into this to get it developed. So I think that what it means is we're not going to really know for a while, and even when we do know, people are going to be making new ones based on the experience with the first one.
Absolutely.
So I think we're just going to have to say the way we're going to know this is by listening to public health, listening to CDC, and being independent, evaluators, each of our own, and say, let me read the data and let me think about this for myself. Guys, thoughts about that? Phil, first.
Absolutely. The phrase we're using a lot these days is we are actually building a plane while we're flying it. And,
hey, they stole that from us. We started that, actually, Jessica Calderich. And Lee Norman stole it from us. We were here first when we used that. He was on the program that day.
It's just, and that is such a perfect analogy for it because of the fact that we just don't know. We have to make our best decisions each and every day and do what's right before us. And I think it's going to be more important to get the vaccine as soon as we know it's out there and safe. Rather than waiting around to see later what the results are and which one may be better than the other.
Yeah, that's it. And by the way, the rest of that analogy goes, we're building the airplane while we fly it, and sometimes the parts don't fit. So.
and we're wearing masks while we're doing it.
And we're wearing a mask while we're doing it. That's right. And washing our hands. And keeping our distance.
And goggles. I think that, moving forward, nobody cared about the shingles vaccine that was being developed. There wasn't all the hype and the constant monitoring of what was going on. Same thing with the pneumonia vaccine, Pneumovax. All of these vaccines, this is a very different time where everybody, media outlets, the public is up on the most recent information. So the science will be followed, but I think it's also important to understand that there will be extensive and high-intensity research and collection of data after it is marketed and once it is being given. So it won't just stop there, but people will continue to understand new data that comes forth, because at that point, you're going to have so many people vaccinated, you will have more data points to really evaluate. And again, hopefully to start with, there will be minimum efficacy and safety standards, which I assume there will be. But even moving forward, once all these vaccines are rolled out, it will still be an intense time to collect all the data and really develop the best platforms and develop the best processes moving forward.
Have we covered how fast this shot would be effective,
We've not. We can talk a
And-
little bit about that.
how often you have to get it,
Yeah.
and does it have a season like
Yeah,
flu?
very sure. Let's hit about that. So the latter we don't really know yet, but the first two questions: how long will it take to rev up your immune
I
system?
don't remember what happened in the phase 1 trials where they looked at how much antibodies made or anything like that. But typically for vaccines, we usually say it's about 14 days. So in that 10 to 14 day frame is when your immune system is going to have built up enough immunity. Certainly for influenza vaccine, we really say by 14 days you should have immune function against influenza. But just 1 or 2 days after the vaccine is probably not going to be
And
enough.
Phil, I think that's probably the same thing y'all are thinking.
Yeah, that's the best we have at this point.
And we won't know for quite a while, I don't think, how long that vaccination is going to last. Because, I mean, if you look at the SARS-CoV-2 data and your antibodies begin to wane, and by 6 months, you'd say, well, gosh, maybe we have to get it twice a year. But we don't know that until we see what this goes on and what the challenge data looks like.
Yeah, absolutely.
Phil, any other thoughts around that one?
I think you've covered that perfectly.
And so the last part of it is, do we have to, will the virus morph? And I'm sure the virus morphs, but I think most of these are being made toward the spike protein. And the spike protein is the part that makes this coronavirus so bad. And so as a result, if this coronavirus loses a spike protein and isn't so bad anymore, then it's just regular coronavirus and we don't care so much.
Right.
That's my logic there, guys.
Yeah, I think a lot of these vaccines, so some of them are fusion proteins, meaning they're actually making the spike protein. So then on that protein, you have a lot of epitopes or areas within that protein which your immune system can recognize. Some of the other ones are just creating vaccines towards specific conserved regions on that spike protein. But most all of them are directed against the spike protein in one form or another. Because that is really, the business end of the virus, and that's what attaches to our receptors in our body. So at this point, they look conserved. It doesn't look like there's any significant mutation that would affect that. But again, moving forward, that is one of the other things that is going to be constantly monitored as well.
And as I recall, this vaccine is really done and by injecting it into the muscle with some sort of a vector, maybe a viral vector, maybe a non-viral vector. And then the pieces of the COVID-19 or the SARS-CoV-2 that have been in part of that vaccine are sitting in your muscle, and your body begins to develop an immune response to that. Is that the theory? And then you're ready for SARS-CoV-2 when it comes out because your body's already seen it.
Yeah, again, some of these are spike protein, the fusion protein. Some are mRNA or DNA, which is the genomic material. So your body will actually create those spikes as well. Your cell's machinery, but then your body will recognize it, your immune system will recognize it as foreign and start to attack and create memory cell responses, T cell responses, B cell responses, things of that nature.
Yeah, and you could see, guys, you think, oh, we're manipulating the human body, we're manipulating our own immune system, and that scares us. And I think a lot of people are afraid of that because of it. They're afraid of the manipulation. And, as with any therapy you ever take, think of the vaccine as a drug. And when you're presented with a drug, you look at the risk and benefit of that drug. And you think to yourself, okay, am I better off with or without it? And that's really the calculus we all have to do. That's true of the flu shot you take every year. It's true of the measles, mumps, and rubella.
Yeah.
It's true of, tetanus. Are you better with it or are you better without it? And I think in this case, especially with how vulnerable some people are to the SARS-CoV-2 virus, I think it's going to be we're better with taking the vaccine than without. But we'll have to look at the data and see what it shows us when it is available.
Yeah, let's not forget, we actually give live viruses to you as a vaccine to create a robust immune system. And this is something that has been done forever in the vaccine. So we're actually giving you a full live virus for some of these vaccines.
We do, and yet you do okay with that.
Isaac wants to know, I'm an essential worker by virtue of my job at Target. Would that put me near the front of the line?
Okay, Phil, that's your question. Target worker, essential. Grocery store worker, same.
They will be in that early phase 2 portion when I said we will continue to look at essential workers after that. So initially it'll be healthcare workers and those associated with quick exposure to those with COVID, and then first responders, and then certainly essential workers will be up in the early part of phase 2.
Okay.
If I'm a healthcare worker and I work with someone who is considered an essential worker, will my partner get the flu shot the same time I do if I'm a healthcare worker?
I mean, COVID shot.
I mean, COVID.
Yeah, yeah,
Thank
yeah.
you.
Yeah, so it's a great question. I think it's still going to be the healthcare worker gets it, and then when it rolls around, the essential worker gets it.
That's still one of the questions up right now. When you look back to H1N1, it was healthcare workers and their families, and there's some efficacy in looking at the fact that that may be the case in this situation as well. That and again, if we knew more about supply today, we would know a lot more. But it's going to be important that we're putting that cocoon around, so to speak, as well too.
Joanne asks, smaller communities do not have Walgreens and CVS. Will they extend, I guess, being this COVID?
Well, I think the question is, how will KDHE get to smaller communities?
Yeah.
How will we get the vaccine distributed?
So the issue, and I think they're getting at the long-term care facility question there, and with that, Walgreens and CVS do have nationwide contracts. They are supposed to expand out to places they normally would not be. However, we are also working like with Kansas Pharmacists Association and working with independent pharmacies across the state to build a network there as well. So again, it's multifaceted where we're working in every possible direction, and we will get allocations out where they need to be.
And for people who are shut in, there's a whole network of home health agencies, I suspect, that are part of your consideration and discussion as well.
Yes.
So Martin wants to know, KDHE Secretary Dr. Norman compared the vaccine, the COVID vaccine, to the flu, in that the flu each year has different strains of flu. Will the COVID vaccine be similar, in your opinion?
Hawkeye, what do you think? It could morph a little bit every year, but really this is about that spike protein.
Yeah. Right now we know that this coronavirus really changes pretty slowly. We know that RNA viruses, and this is an RNA virus as opposed to a DNA virus, we know that they can mutate because inherently when they replicate, they are just error prone. The same thing happens for HIV. We know that that's error prone. Again, 9 out of 10 mutations with this virus are deleterious and it cause it to not replicate correctly. We know that there have been a lot of catalog mutations, but none of these mutations has really affected the clinical change or has affected the clinical outcome or natural history of the virus. They are all similar to the original presentation in Wuhan to they are now. There's not a lot of thought and concern that it will mutate or change to a different strain as flu does because they are separate, different viruses. There's always that chance, but right now there's not a large concern that it will mutate into some sort of new strain. Again, there's always a chance, but so far there is no clinically different strain from the original Wuhan strain.
So you think about the measles vaccine, we don't really have to change how that's made up every year, right? It's pretty much the same vaccine every year and for everybody. And so I think that's kind of how we think the coronavirus vaccine will fall. Okay,
so on that question, though, with measles, I only have to get one, right?
You do, because you get lifelong immunity from it, and that's different than things like influenza and this. Okay. What we think, we don't know yet about COVID.
So that's a question towards the durability. It's a very durable immune response that we have to that vaccine.
One more question, then we have to roll.
Oh, my gosh. Okay. Well, I guess I'll just take whatever I have here.
I've got a question for Phil. Phil, are you getting any sleep?
I think I last slept in the middle of March.
Yeah, I understand that one.
All right, I'll go with this one. John wants to know who's going to pay for all this.
Okay, Phil, how are we paying for the vaccines?
Everything is coming out from the federal government with all the vaccine will be available at no cost. There is an ability for providers to charge an administration fee, but it cannot stand in the way of receiving of the virus. So an administration fee is pretty common. Insurance companies pick that up. But if you're uninsured, there will be plenty of mechanisms where cost will not be an issue, but it will be through the national vaccination program.
I'll tell you what, that's one thing you have to just say, that's one good reason that we want a strong public health prevention program for something like this, because it makes all the difference when we go.
We have about 20 or 30 more questions. Can Phil come back? That's what I want to
Phil,
know.
we'll bring you back.
I'd
right.
be happy to.
Well, and if you're not doing anything at 5 o'clock tonight, I'll have you join the chairs meeting, unless you're probably busy. But if you're not, let me know. All right, listen, folks, first of all, our hats off, a big thank you to Phil Griffin, and just special thoughts about tomorrow. Dr. Becky Lowry, one of our internists in general and geriatric medicine, is joined by Dr. Ravi, I probably won't say this right, Sabapathy, a psychologist over at Advent Health, to update frontline workers about the state of mind of frontline workers and what they're doing to hold up during this coronavirus marathon. Also, remember to send us your mask picture. So first, Dr. Griffin, final thoughts about things today?
I would just like to point out we do have the COVID-19 vaccination plan is in draft form that just went up on the KDHE coronavirus website yesterday afternoon. So it's a very high-level plan that will be a living document that will change and grow as it comes along. But if people want to see a little bit more, there is information out there now.
Thank you. Hawk, final thoughts?
I see the CDC has recently recommended wearing masks on mass transit and public places of that nature. Hopefully our listeners and our viewers have been ahead of the curve and been doing that.
We've been recommending
anyways,
that for a while,
and
I
airports
suspect.
especially.
Yeah.
So I think that's good. More validation. I'm sure that they always wanted it, but now they have the data to back that up.
They've been listening to us. Thank goodness.
That's right.
It's about time. Okay, so John is demonstrating great mask work here. He's a retired military and airline pilot and longtime Morning Update viewer. Says he's still wearing the mask his wife made him. Hopefully you've watched that a couple times. He knows a thing or two about keeping up the good fight and reminds us, don't let your guard down. Hey, we've talked a lot about vaccinations. Just remember that that's only one defense against the virus. There are a lot of great things you can do out there, and we talk about them on this program every day. It's the pillars of infection control. Wear a mask, wash your hands, keep your distance, don't go out if you're sick, don't cough into your elbow, and, remember that throughout all of COVID, we've tried to tell you the truth. We've tried to keep ourselves from flapjacking, just going straight at you with the truth and what we know to be true, and trying to cope with COVID weariness syndrome. Cows. We'll be talking more about that tomorrow. And until then, there's still no place like home. We'll see you tomorrow.
If you're aiming at what keeps your family safe from coronavirus, think of each of the things on the list here as a slice of Swiss cheese with the holes in slightly different spots. So physical distancing, one intervention, one barrier, but not 100% perfect. Mask wearing, another intervention, another barrier, but not 100% perfect. Hand hygiene, right? Frequent hand washing, another intervention. And then rapid testing in symptomatic patients or those who are exposed. Each of these things matters. We know that if you do them, you can keep yourself safe.